this is a change from the program in that we're talking about early pregnancy and very early pregnancy here, less than 10 weeks. All of the other talks are on later pregnancy, so you've got to change your mindset here a little bit. And we were instructed by Michael to discuss the guidelines, as you know. So we have the guidelines there. We had one guideline, the first guideline in the series by Peter McParland on the ultrasound diagnosis, and this was produced in 2010. And Nadine then followed up with a guideline on the management of early pregnancy miscarriage. And we have another guideline. I'll get a plug in for the Ectopic Pregnancy guideline, and the mid-trimester will be presented in December at a meeting in the college, so I'm sure that you look forward to that. Now, a little bit of anatomy. If we look, I suppose, here, and the reason I want to show you this is just to maybe explain the detail of the little times that are so important when people are discussing the diagnosis and management of early pregnancy miscarriage. You can see there these are weeks after conception, and the first two, 1 and 2 there weeks are I suppose implantation, where in the first, the number 1, you can see where there is the blastocyst is formed, and then is more or less implanting then during that second week, so that when it comes into the embryo stage, after another week, the embryo is formed, and at that stage, with the gastrulation is referring there to the triple layer where the organs are formed. And by the time it comes to the number 3 there on the diagram, this, I suppose, we would usually refer to as a gestation week 5. So coming in there at 5 and 6 will be the stage where we can determine by ultrasound scan that the little embryo is alive. So if I just show it to you in a different way here, so the numbers now are slightly different, so that the 1, 2, 3, 4, 5 down the side are gestation weeks. So we have the number 1 and 2, obviously, where there's nothing happening, and then the approach that people are beginning to take nowadays is to look on it for the different stages there, for the implantation during those first 2 weeks, and moving on then to a pre-embryo stage, and then embryo until 10 weeks. So I think at the 10 weeks we've gone out of the early pregnancy zone. Now, in the transvaginal scan bit there, you can see at the end of the 4th week, it might be possible to see an eccentric sac on ultrasound. And this will be a very small sac, a diameter of about 2 millimeters. In the next week, the pre-embryo stage, again, there will usually be an intrauterine sac visible and a yolk sac towards the end of that week. Again, about a 5 millimeter mean sac diameter. Now, the following week, this is week 6, the embryo appears and is 2 millimeters there, grows, I suppose, conveniently by about 1 millimeter a day, so that from that week you would expect roughly that the embryo will grow from 2 millimeters to 9 millimeters. And when it reaches the 9 millimeters, from a scan point of view, we're more or less home and dry and we know what's going on. So the time really that we're looking at earlier on is the time when a lot of the miscarriages happen. Most miscarriages will happen during that implantation and pre-embryo stage. But it's also the stage where we can't see. If we want to use scan, the scan is very useful from about 9 millimeters on. So that there is this zone where people are attending with symptoms about 5 or 6 weeks, where a lot of miscarriages are happening and where it's sometimes a little tricky to give a prognosis. So I suppose now I want to show you a picture of this guy. This is Yazan Abdallah is his name, and he's recently been appointed as lecturer in the Hammersmith in ONG, and he, I suppose, will be remembered for a paper that was written 3 years ago on the limitations of definitions of CRL and sac diameter. And they did a study between some of the London hospitals and Leuven in Belgium, and they looked at women who had presented early in pregnancy, and they did the ultrasound scan, and then they mapped them through to see whether or not they were able to predict that the pregnancy was viable or not. And they came up with a fairly, I suppose, startling conclusion at the time. Now, this is just, remember, 3 years ago, that if people were using a CRL cutoff of 5 millimeters, that there was an 8.3% chance of a false positive diagnosis of a miscarriage. So at the time, 3 years ago, certainly in the US, people were using 4 and 5 millimeters, and the RCOG were using 6 millimeters. So there was a fairly immediate response from the RCOG, and a few weeks after that article was published, they produced this addendum to the guideline on miscarriage, and they stated with immediate effect that the ultrasound diagnosis could be made of a miscarriage with the crown rump length of greater than or equal to 7 millimeters. So I suppose this was moving it out a millimeter or two from what they had previously. And it also moved out the scan size from 20 to 25 millimeters. They also recommended that TV scans be done. And they also then brought in the recommendation or the concern that if there was any concern about the security of the scan, or about the quality of the scan, or about the woman having any doubt, or whatever, that another scan could be arranged after a week, and then base any diagnosis on the difference between the scans. So this is I suppose this was taken up by the RCOG, and certainly by those working in the UK. And as you saw earlier, some of the RCOG guidelines now have been taken up by NICE, and the RCOG guideline on miscarriage now has been incorporated into a joint document with NICE. This is Ectopic Pregnancy and Miscarriage Guideline that was published in December 2012. And this, I suppose, it's interesting in the approach that's taken. And from the diagnosis point of view, there's an emphasis on the support and on the information given to women that was something that really came to the fore during the few years before that, including our own miscarriage misdiagnosis review, and a lot of countries were going through similar sort of soul searching about how they manage miscarriage. They recommended also that there should be a 7-day EPU service, and we're also looking at the possibility of self-referrals for different women. And interestingly, I suppose, from the point of view of who they would see and who they wouldn't see, they said if somebody had pain or they were greater than 6 weeks, they were welcome to come to the EPU. But if somebody presented with painless bleeding at less than 6 weeks, they were not really welcome to attend. And again, they recommended TVS. And hormonally, they said HCG didn't, and they had no time at all for progesterone. That's something now that I'll maybe discuss later. Now, with the management, NICE recommended expectant management, so that the first-line strategy is to wait and wait for a natural miscarriage. Only if a woman is not happy with that will she be offered medical therapy. And surgical is the choice, obviously, if somebody is bleeding heavily or whatever and needs it. But again, it's very much a stepwise progression that you have to really consider and use the expectant management and work your way up to the surgical. And even when you get to the surgical stage, then there's a strong recommendation for vacuum aspiration under local. And I suppose this is something that they've been doing in the States for a long time, but maybe in the UK, and it hasn't really gained acceptance yet as a standard. And again, they recommend laparoscopy for ectopics and salpingectomy. Again, the salpingectomy, I suppose, is made by the finance guys, where they say that if you take out the tube, at least you're certainly going to win on the bottom line there. And again, I suppose that's something that could be considered in a broader way. Now, our own miscarriage misdiagnosis review by Professor Ledger was published in April 2011, I think, just over 3 years ago. And there were a number of recommendations from that review that were largely to do with the organisation and the management of the service, rather than will it be 7 millimetres or 5 millimetres or whatever. And they have largely been taken in hand by the clinical care programme. And we obviously now we're looking at an EPU in every maternity unit. And we're looking at direct access for GPs and selected patient groups again. And we're looking at training and specific training for those that are involved in scanning. And obviously the ultrasound scan machines themselves are all up to scratch. So that whatever Bill Ledger did recommend has more or less been put into place in that regard. The monitoring is obviously continuing as part of the programme. So getting back to the guidelines, sorry now to digress. Guideline number 1, early diagnosis of miscarriage. This was produced in 2010. CRL, now in the written guideline that we have, it says CRL of greater than 7 millimetres. It's okay to make a diagnosis based on a single TVS that is a miscarriage. In the same way, with a mean sac diameter of greater than 20 millimetres with an empty sac. Now, interestingly, when Nadine then did the management of miscarriage, she did take on board what had previously been said with regard to greater than 7 millimetres, but also mentioned in the next paragraph that there was this acknowledgement now that 7 millimetres itself is probably sufficient to reach a diagnosis. And so I suppose maybe as we go on, we'll need to have perhaps a little bit better agreement. I mean, it is. I suppose practically, I suppose most people are using 7. Now, all right. What about the question of the second scan? In guideline number 10, Nadine's guideline, if there's doubt about the diagnosis, if the first scan is before 8 weeks, and then I think this concept of the first scan before 8 weeks is coming from the miscarriage misdiagnosis. This was the only, I suppose, practical instruction that was given in that guideline, that if it's before 8 weeks, it's hazardous, is the word that was used. It's hazardous to make a diagnosis of miscarriage. Okay, maybe. Well, it depends on how much before 8 weeks it is. But anyway, hazardous it is. Now, also, if I suppose if you've got SHOs and registrars doing scans in the middle of the night and they're doing abdominal scans or whatever, it's very reasonable to do another scan. And for women who are presenting, I suppose, with a long cycle and asymptomatic, again, it's hard if you don't see very much there to be making a diagnosis with those women. Now, getting back to the NICE guideline in 2012, the recommendation there is a second scan should be done in 1 week if the CRL is less than 7. So they will acknowledge if it's 7 millimetres, no fetal heart, then you've made your diagnosis. But they will also say that you could have a second opinion and or a scan in 1 week if the CRL is equal to 7 or more. So there is no place that NICE are saying that somebody can walk into you with a baby with a CRL of 10 and no fetal heart, and you can just say to her, okay, miscarriage, let's go down to theatre. So they're building in a lot of delay there in reaching a diagnosis. And it's I suppose it's a little bit woolly in the way it's been set up, and I think it reflects a lot of what is there in that particular guideline. I don't know. There is no recognition whatsoever of even a borderline case, or even if somebody is definitely and clearly a miscarriage, that they can be managed surgically appropriately if needed. And there's a heavy emphasis there on not doing anything. So if a second scan for a woman's request, and it's often the case, I suppose, that a woman will present and that she gets this result of the scan, and it's entirely reasonable in that case. It's entirely reasonable in that case to sit back, but not every woman wants to do that. And obviously there are a lot of women who will come in and get a diagnosis, and they'll say, I need to fix this. And so that has to be, I suppose, considered as well. Now, what will we do? We were told to have little flowchart thingies here, so this is a flowchart, I think. Miscarriage. So if you look down on the left, condition stable with an incomplete miscarriage. I mean, an incomplete miscarriage the outcome is so good with conservative management that there's no contest there. So anybody with an incomplete miscarriage, that means where there's Protestant conception but there's no sac visible or whatever, they should really be promoted into the do nothing group. Likewise, on the right with the heavy bleeding, miscarriage, big sac, etc., they probably need surgical management. But then you've got a big group in the centre there generally with the way EPUs are run nowadays, these women will present with a sac still in place and of a stable condition, and a diagnosis is made of miscarriage. Now, they can go either route. They can go the conservative if that's what they want. They can go the medical with misoprostol, or the surgical. So it's horses for courses, and I think it's certainly a lot of what we do is explain what's going on to the women and let them decide themselves. And I think if you provide the options, I mean, there certainly isn't. There certainly isn't much more that needs to be done. I think on the nice one, the women will be more or less shunted into the kind of come back in a week or two, and whether that's something that we should be doing, I leave that up to you to decide. Now, in Mullingar, there's one, I suppose, I was talking about the progesterone side. You know, we do HCG and progesterone at every visit, and it's the reason that we do this is because in some cases, in some of the early cases with 2 HCGs, you know straight away that things are good. If you've got a good doubling in a few days, that you know immediately, and it makes it much easier to manage patients, and it makes it much easier to validate your scan. And if it's somewhere where instead of doing a scan in a week or two, if you've got your bloods there straight away, it's certainly much quicker from the patient's point of view. Again, there's an issue of a scan with an empty uterus. Is it an ectopic? Is it a complete miscarriage? And again, if you have got a HCG falling, it does again make these patients much easier to manage. And I know that in some cases, these patients will have to be brought back or whatever. And again, you can cut down on visits by using bloods. And I suppose from the point of view of accessibility for patients coming into EPU, there is generally a feeling, I suppose, that patients shouldn't be seen too early, and this in some ways might not be what the patients themselves want. I mean, if the patient presents at 5.5 weeks or 6 weeks with bleeding, then she wants to be seen. And so is it a good thing that we say, okay, we can't see you till 7.5 weeks or whatever? I don't know. I mean, certainly, I think there's room to consider bloods in these kind of patients. Again, you can use bloods for outpatient managers. So again, and the early ones with no sac or whatever will include your ectopics. So it means that you're admitting less and less patients if you have more of a handle on them at an earlier stage. And from the cost point of view, there's very little because the bloods can all be done. They can all be done pretty much at the same time. Now, I wanted to give you ectopic pregnancy. For those of you who can't make it to the December meeting, I want to give you a few little pointers from the talk. Number one, I suppose, has been pointed out by the CMACE as well, is that women who present acutely, particularly, and they were pointed out with diarrhea, dizziness, vomiting, with what's not expected at all to be anything to do with pregnancy. If that woman is of an age where she could be pregnant and she's presenting to an acute service, she should have a urinary pregnancy test done. And certainly this has been pointed out by the CMACE and is something that we should take on board. Again, TVS is far superior when it comes to diagnosis of ectopic, and most women nowadays with an ectopic pregnancy will have a positive diagnosis of a mass. And if there isn't a positive diagnosis of a mass, and if there isn't free fluid in there, then there's obviously then plenty of time to wait and see what is happening with that woman. Now, if we meet somebody who's new and they're looking at the HCG and they're saying, oh, the HCG there is 2,000 and I can't see a pregnancy, it must be an ectopic. We would always beware of that, because the figures for those HCG of 2,000 or 1,500 or whatever they are coming from series of normal pregnancies. And it has been I suppose, noticed over the last few years that as women are coming to EPUs with abnormal pregnancies, they're not always so easy to see on scan. And certainly you can have women with 2,000 or 3,000 of HCG with an intrauterine pregnancy that's not seen on scan. And again, the message is really that the discriminatory zone should only be used in conjunction with the clinical findings. Now, as regards management of ectopic pregnancy, there is a general move to expectant management in the same way as there is for miscarriage, and particularly for a small mass and a falling HCG, it's almost for a woman with doesn't have big symptoms or whatever, it's definitely recommended that expectant management is done, particularly when we have the EPU service then to monitor and follow her up. Methotrexate, looking at the Irish figures, has taken off in the last 4 or 5 years, and is useful again though for where it's not too very big and HCG not too high, and surgical obviously then for all others. Now, there were 2 big series. There was one from France and one from Netherlands in the last year or so, looking at salpingotomy versus salpingectomy, and they're more or less coming down on the side of salpingectomy. And I don't know. I don't think that question is answered yet. And there's probably a marginal benefit in the salpingotomy for future pregnancies, although that hasn't been found in the trials. And the great benefit of the salpingectomy is that there's definitely a lower rate of persistent gestational tissue in the treated tube. So the approach that I personally take is that I explain this to a woman with an ectopic and give her the trade-off, and invariably the woman will go for tube preserving. I'm interested, there was one study done in Holland looking at this, and they came up with the solution from what they told the women, that the women would prefer the salpingectomy. So it depends, I suppose, on what question you ask, and you'll get the answer. You'll always get the answer, won't you, if you want. Now, resources. I think there should be a dedicated OBGYN when somebody presents to a hospital. They shouldn't be landing up in casualty with all the riffraff with sore ankles and the rest of it, and we should really insist that we've got our own facility. And again, I think with the EPU setup is maybe needs a little bit of a shift now at the moment, and a little bit of encouragement to keep it going and work on it. And as there's more and more work going, we need to make sure that the staffing is kept up and not being eroded away off into other parts of the hospital. Maybe we should look again at the scan machines, where again there is more work and there's more scanning and pregnancy anticipated, and we need to send Michael Turner out to get another round of scan machines. Communication. should we have a national association of EPUs? We've 19 EPUs in Ireland, and there's 10 times that number in the UK. Now, the UK EPUs are very well organised together as the Association of Early Pregnancy Units, and they've always had this nice little picture of the little flowers, the little bluebells, and they convey a very, I suppose, a very get-together and a very caring image. And they say this is their new logo now, and they say that the bluebell, it's a very strong flower, and it's kind of it gives them an image of being strong and caring, and there are, I suppose, some of our people have gone over and have joined up with them. Kerry General Hospital, Letterkenny, Rotunda, Wexford are part of the Irish contingent of the association. Should we be looking after our own? Why would we do that? Maybe clinical research using a network, or maybe looking at things like what should we be doing with HCGs, or how should we manage miscarriage? I mean, there are a lot of questions that we need to look at, I suppose, as a nation. What are we doing about same-day surgery and ERPC? Should we be calling ERPC now SMM, surgical management of miscarriage, because people don't like calling it products of conception? Should we be doing it under local? I don't know. Yeah. Looking forward. Oh yeah, this is my looking forward slide. Yeah. EPU is the new versus the traditional A&E and the hospital admission and the delayed scanning, etc., etc., etc. So I suppose if you look at the two choices there, it's quite obvious in some ways that the EPU gives a more streamlined, efficient service, and if the alternative is the old style hospital admission, etc., etc., and if we're in a position now where we have zero additional resources, then I think that maybe we should shift. And my message for the day is to put the people where you get the best value out of them. Thank you very much.